Hi, I'm Colleen Bamford, and welcome to Health Watch InDepth, presented by UMass Memorial Health Care. On today's show, we're going to take a look at arthritis and joint replacement. In a few moments, we will be joined by experts from UMass Memorial in this field. But first, let me introduce you to a doctor turned patient.
Hi, I'm Dr. Deborah DeMarco, and I'm a rheumatologist at UMass. I had a knee replacement in 2009. I was a marathon runner for a number of years. I've exercised pretty much my whole life. 2005, I started to notice pain while I was running in my right knee. Of course, I ignored it, being a physician and being a rheumatologist. And then I started taking anti-inflammatories as needed, some Tylenol. But I reached a point where I continued to have pain and finally sought medical attention. I had my first knee arthroscopy at UMass Memorial in Marlborough, and it didn't really make much of a difference. I was still able to run, but it was becoming apparent that I was going to have to give up running at some point. In about 2008, I first saw Dr. Ayers. I never had a major injury to my knee, but I do have a family history of osteoarthritis in my mother and other family members. So I guess it wasn't such a big surprise. Had the knee replacement in January of 2009. I decided that I was going to behave and be a good patient rather than be a physician. My experience was really much smoother than I ever expected. When I was trying to decide where to have the surgery, I looked into Boston hospitals and area hospitals, but ultimately chose UMass because of the reputation of the surgeons, the nursing care, experience that my patients have had at UMass with good outcomes and good care there. And I didn't really see any reason to have to travel out of my own community to have the surgery. The nursing care was phenomenal. It was just, they were like angels. The physical therapy, as I tell patients, is really very, very difficult. At about 8 days, I started formal physical therapy at a physical therapy location. You go 3 times a week. You have to do a lot of it on your own at home, so it does. He kind of laughed at me when I asked him how soon I could go back to work, and he said, "Physical therapy is your job," and he's right. I had a great therapist who I worked with. I did whatever I was supposed to do at home and then some probably, and was driving in about 3.5 weeks, which is, I think, a little fast, but and then was back to work at about 7 weeks. I have no pain in the knee that was replaced. I sort of converted myself into a cyclist and do long distance century rides, which is 100 miles with no pain at all. And in fact, I put 3,600 miles on my bike last season. So I remember the first day I got on my bike after the surgery. I was nervous, of course, because anything I did after the surgery, I was nervous that I was going to harm the prosthesis. So one of my riding partners drove me up to a bike path. And we felt that was the safest place if I fell off the bike without, to be there without cars. And it was a great feeling to be able to get on the bike and get out again and do some of the things that I enjoy doing. Being able to walk my dog again, for a long distance. I'm asked all the time by patients as well as friends and friends of friends, when is the right time to have the surgery? And it's really a very personal decision. For me, I went from being able to run a marathon to not being able to walk my dog around the block without having pain. So I was young to have a knee replacement, and I might face having a revision because I was young, but to me, the lifestyle issue was the most important, and being able to do the things and the activities that I like to do. You worry about what type of outcome you're going to have, I think. Was I going to be able to do the things that I really wanted to do? And basically the only thing I can't do is run. So I would say I had an excellent outcome.
Welcome back to Health Watch InDepth, presented by UMass Memorial Health Care. Joining me now are 2 well-known experts on joint replacement, and as we're going over the whole process, I wanted to start with both of you, and you can introduce yourselves and your areas of expertise, and when you would most likely see a patient and what symptoms they might present. So we'll begin with you, closest to me.
Great. So I'm Dr. Catherine Upchurch. I'm the clinical chief of the Division of Rheumatology at UMass Memorial Health Care.
And I'm Dr. Jennifer Boehm. I'm a physiatrist at UMass, and my role is helping patients with exercise recommendations for their joint pain.
As a rheumatologist, I specialize in the medical management of patients with all sorts of joint pain. Particularly today, we're generally focusing on osteoarthritis, which is wear and tear arthritis. So pain is the symptom that ordinarily brings a patient in to see me. Produce a very comprehensive program of strategies to try to minimize their pain. But then a very important role I have is to get to know the patient, work with them, and help them understand when they're ready for a joint replacement.
If someone comes in and they're having pain, they might say, that's it, I've heard knee replacement is the way to go, or joint replacement in other areas of the body. What do you typically tell them? Where should they begin to manage the pain before they have to make a decision, as you mentioned, towards surgery?
Well, what we emphasize are several different approaches. The first approach is basically non-medical or non-pharmacological. So conservative management, for example, would include weight reduction in patients who are overweight, which is a very common associated risk factor. Other non-medical or non-pharmacological approaches would be things like strengthening of the muscles above the knee, and I know Dr. Bema will be talking about that. Maybe you can chime in and say what you'd be doing there.
Yeah.
Absolutely. I think so many patients are afraid to exercise when they have pain. So I think one of the things we first do is say, okay, this is safe and this is not safe. This is what you should be thinking about, and this is what you shouldn't know. Question I get a lot of times is, does running cause this problem? And there's actually no evidence that running causes osteoarthritis. However, if you have a swollen knee, you should not be running on that knee. So a lot of times we're examining the individual patient and deciding what's best for them in that situation. It really depends not only on their symptoms, but also on their radiographic findings and what they've tried and what their activity level is before the surgery. For example, an overweight patient who is focusing on weight loss may have a different time than, a young marathon runner who's having some joint pain symptoms. So we have to consider all of their risk factors and their lifestyle choices when we're making these recommendations. Another question that I get a lot is, what if it hurts too much to exercise on land? And that happens, so a lot of times we'll put the patients in water. So aquatic physical therapy is actually an option for this, and I do find a lot of patients get relief with this. I know the American College of Rheumatology recommends exercise for this, so it's part of both of our treatments, I think.
Is this a good idea, even if someone is going down the road to surgery, to do the exercise regimen to add strength?
Absolutely. So we know that exercise helps with your heart, your lungs, and your bone density. So not only does it help to strengthen the muscles around the area, which are going to be compromised with any kind of surgery, it helps with your bone density, it helps with your heart and lungs. It probably decreases the risk of the surgery itself. So we do always recommend exercise. I think the trick is finding an exercise the patient can do without pain. And a lot of times we'll enlist the help of our excellent physical therapists here at UMass. Our physical therapy department is located at Hanneman, and they're very good at helping strategize with this. And if the patient has trouble with the land-based strengthening exercises, we'll switch them over to water. So usually there's a way around the problem. We just have to find it, and we try to tailor that to the individual patient and their needs.
Are you finding similar questions or fears that people are coming in with this joint pain, that they have been sitting around thinking, maybe the swelling, maybe the pain will go away if I do nothing?
Right. Well, actually, we can refer to the medical literature. Years ago, there was a study in which two groups of patients were studied. One group was a control group that did not pursue any activity. Another group, as I described them, I described Group A as couch potatoes when I discuss it with my patients, and the other group were randomized to the exercise group. And even though we don't have the capability yet in the area of current state of medicine to change the course of osteoarthritis, what we can do is improve symptoms, and the couch potatoes didn't do as well as the patients who actually pursued a graded exercise program. So there's data to support this, and I'm sure that's the same in your field. And the second point is that the orthopedic surgeons really hope to regain function in addition to improving pain. So the most function that the patient can have, the more function that the patient can have, the better. So we would encourage patients to be able to extend their knee as fully as possible, and to try to flex their knee as much as possible as well before the surgery, which will make the outcome of the surgery potentially better.
Are some people more prone to these conditions, the way that they're they're built?
Well, I think some people are born with certain abnormalities that lead to osteoarthritis. For example, people who are born with congenital hip disease, we know, will go on often to develop osteoarthritis prematurely. There are certain genetic diseases that are associated with osteoarthritis, and we know even in a less well-defined way that there are families who have genetic factors that lead to osteoarthritis. In general, though, I think injuries earlier on lead to later in life osteoarthritis. I tell people that if they played basketball for the Celtics, there's about a 100% chance that they would be seeing Dr. Ayers or other orthopedic surgeons at some time in their life. So injuries, previous sports injuries, are a major cause of osteoarthritis down the road. So there's a wide array of osteoarthritis etiologies in the weight-bearing joints.
Is there anything you can do to prevent it so someone doesn't even have to get to the point to see either of you?
Well, I think avoidance of major risk factors such as being significantly overweight may be helpful.
Okay.
I think that's a known risk factor. Trying to avoid certain occupations that may be associated with an increased incidence. I agree that there's no firm data that jogging, as odd as it might sound, which is a pounding exercise, there's no data to support the fact that it causes osteoarthritis. I think maintaining muscle tone is as good a preventive strategy as you can do. Sadly, though, we really don't know enough about the biology of osteoarthritis to be able to prevent it yet, but we're getting closer.
Okay. Dr. Vema, I see you
And
shaking
I think
your
that
head.
can be a very frustrating thing for patients. So many times patients come in and they say, what medicine can I take to prevent this? And gosh, don't we wish we had something that was the case. But I think, we do know that obesity is associated and is a risk factor, and we do know that exercise helps for obesity. So we want to, when we're developing an exercise program, it's always helpful to consider strength training and aerobic exercise because we want to protect our bone health as well as lose weight. And I think it's very hard to lose weight by just restricting calories. Some people can do it and some people do it very well, but I think that combination of restricting calories as well as increasing your exercise really makes the difference in weight loss. And I think that's one way that we can take control and really at least treat the symptoms, if not prevent osteoarthritis. And we know from the rheumatologic literature that actually moderate exercise is helpful for symptomatic osteoarthritis. It doesn't prevent it. It doesn't, if this is in your family and this is something that you're going to get, this is unfortunately what's going to happen. But in terms of feeling better and having less joint pain, if you exercise, it is very likely that will be the case.
When do you get to the point that someone has to have surgery or recommend surgery?
Well, let me add a couple of steps
Sure.
between conservative management and surgery.
Absolutely.
So we pursue a treatment with analgesics such as Tylenol. Uncommonly, we try now particularly to avoid very strong pain relieving medications for a variety of reasons, but there are some that are weaker that can be very helpful. The second thing we often do is use nonsteroidal anti-inflammatory drugs judiciously with caution about risk factors and that sort of thing. We inject joints with corticosteroids, which do provide some symptomatic benefit sometimes and often show us some surprises. Occasionally we'll find Lyme disease that we didn't expect or gout that we didn't expect or related conditions, but that can be very temporizing too. And then there's a bit of a debate going on right now about whether injecting very viscous substances that are ultrafiltrates of joint fluid are helpful. I think the jury's not completely in on that one yet, but that has been a strategy that's been used quite a bit. And then one final thing I wanted to mention is the glucosamine myth. Glucosamine is a product that can be bought over the counter without a prescription, and it's not an FDA-approved strategy. And there actually have been some very good scientific studies, one of which was engineered by the National Institutes of Health, and one of which just recently came out in the last month, that suggest or pretty corroborate the fact that glucosamine really doesn't change the course of this problem. I still tell patients if they want to try it, I don't have a problem with it because they may be in the placebo group and they may get benefit. But I also emphasize that in older people on fixed incomes, it's expensive. So if they do try it, there has to be a very concise pre-treatment understanding of the degree of pain and an endpoint. And if they don't get beyond that relief of pain by that endpoint,
Okay.
time out.
Okay. How about you?
So my focus is exercise, as you've already heard. So usually what I'm trying to do is figure out where that arthritis is and how we can get around it for strengthening. So for example, when we send patients for a knee replacement, it's for the weight-bearing surface of the knee. So it's where the thigh bone meets the shin bone is the area that's being treated with that type of surgery. You keep your native kneecap, and I'm sure we're going to hear more about that. But for the arthritis under the kneecap, that actually responds very well to exercise treatment. However, when you have arthritis under the kneecap, it can be very painful to do squats. So sometimes patients say, gosh, I'm going to get and lose that weight, and it's January 1st, and I'm going to have a New Year's resolution to get in the gym. And my personal trainer told me I need to do 200 squats by noon, and then the knee pain acts up. And we can actually treat that by backing off on squats and doing another type of exercise. So it's usually figuring out, okay, where is your arthritis? Where's your pain? And what exercises can we do to make you feel better? And sometimes I'm recommending an independent exercise program. Very often I'm putting the patient with a physical therapist so they can learn a tailored exercise program that treats their needs.
Okay. You wanted to jump in there?
Well, I did. I think coming back to your original question, when and how do we determine or work with a patient to help them determine when a knee replacement might be in the cards? Well, first we have to recognize that they have advanced disease, and that disease would be advanced particularly symptomatically, because sometimes the x-rays don't show as much disease as the patient feels, and sometimes the surgeon goes in and sees much more disease than we can see with our imaging techniques. But I basically ask the patient to answer the following question. When you wake up in the morning, if you think about your day and what you'd like to do during your day, are you limited by your pain? Do you have to change your degree of activity, how you want to spend your time, and do you have to significantly modify your lifestyle because of your knee pain? And that is actually a pretty straightforward question. Most people can answer it. And when they start to think about it and realize that every day their knee pain plays an important role in structuring what they do and what they can't do, they realize that they're getting pretty close. And then it becomes a question of whether they psychologically are ready to undergo what is by all definitions a major procedure with a major potential for rehab and that sort of thing. But I think most people, when they realize that their joint pain is strikingly modifying the quality of their life and the promise of improvement, they come around and realize that they're excited about this and they're ready to jump in. But there is a process, and it does require knowing the patient and answering back to the patient or listening to the patient and telling them what you're hearing.
Okay. Very good advice, very good questions. We have a lot more information coming up. You two have been great, so thank you. Welcome back. Well, again, we have new guests with us, two new guests, one returning guest. I'd like to introduce Dr. David Ayers. Dr. Bema, thank you for returning with us this segment. And Dr. DeMarco, we saw your story and very inspired by it, so we will be speaking with you about your personal experience. I'm going to first swing it over to you, Dr. Ayers, because you have a wealth of knowledge on this. So when people are coming to see you, what stage are they in this whole process?
So Colleen, when people come to see me in the office, there's a wide spectrum of stages that they're in. Some come fairly early in the process to learn more about the disease and ways to try to modify the course. Others are in a middle zone, and some are quite advanced who have very, very severe arthritis, have already tried exercise, diet, activity modification, and medications, and are really coming specifically for surgery. So there's a wide spectrum of patients that I see.
What do you tell them? I mean, when you know that they're at the point that they do need to seek treatment, how do you go about that, and what are you looking for?
So patients who have severe arthritis, we're really trying to evaluate the impact it has on their life. And the two major factors are the amount of pain that they have and how it affects their function.
Okay.
Because that's the two things that really affect the patient's ability to do the things they want to do and to do the things that they have to do. So we want to know how much pain they're having, try to quantify that, how that reacts to treatments that they've tried. And typically for patients who are thinking seriously of surgery, they have pain that cannot be controlled with the other treatment options. And they have very severe limitations in their ability to do the things that they need or want to do.
Okay. You have some, I hate to call them props, but examples.
I do, yes.
That maybe you can show us in this form. What are some examples or studies that you're looking for?
So this is a model of a knee, and arthritis is when the cushion or the articular cartilage between the two bones, the thigh bone or the femur and the tibia bone or the shin bone, when the spacer, which is the cartilage between them, wears away so that the bones rub on each other. I mean, it's easy to understand why that's such a painful condition, because there's no cushion left and the bone actually rubs against the other bone. Causes swelling, causes pain, can cause deformity and lack of motion. What a knee replacement is removing the damaged cartilage on the end of the bone and replacing that with a metal cap on the femur, a metal tray on the top of the shin bone or the tibia, and then a plastic spacer that goes in between. So it's a metal, plastic, metal sandwich, which is really only about 1 inch in thickness. Some people think a knee replacement is replacing the knee from here to here, but it's really just a resurfacing of the joint so that we're replacing the damaged cartilage or cushion with an artificial cushion that is really this plastic metal sandwich. The last part is the kneecap. The kneecap is within a tendon in the front of the knee, and it slides up and down a groove in the metal tray, the metal runner here. And there's often damage, severe damage on the cartilage on the back of the kneecap. And we retain the bone of the kneecap, but we remove the damaged cartilage and put a plastic spacer on the back of the kneecap as well, which slides in the metal groove on the femoral cap.
Is this looking familiar to you?
Yes, unfortunately it is.
Maybe you can, again, we heard a little bit about your story, but what he's explaining and the pain symptoms, talk about your experience.
Yeah, so I, as you heard from the earlier video, I was a long distance runner. I was a marathon runner for a very long time. Never had a major injury, but have a family history of osteoarthritis, and I started to have pain while I was running. Eventually had to stop running, but still had pain at night, really couldn't even walk my dog around the block. So, you know, tried the usual things that you and Dr. Upchurch mentioned, anti-inflammatories, exercise, quadricep strengthening, steroid injections. I think you did a Synvisc injection. And I actually had arthroscopy as well to sort of clean out the joint, but you know, eventually it reached a point where I kind of felt like I was ready because it was interfering with my lifestyle.
She obviously was in good shape, an athlete, a runner, and things just were not working as they properly should in the knee area.
Absolutely. I think this is another frustrating issue for patients because all the time I get, doctor, when do I need a knee replacement? Well, I turn that question back around and say, how are you feeling? You know, how bad is your pain? Can you go upstairs foot over foot, or do you have to bring one foot together when you're trying to do stairs? You know, for someone who's running 26.2 miles, you know, that's a very active person that's going to realize a different level of function than someone who is homebound, who isn't really getting out of their house. So we need to take into consideration what the patient was doing before and ask them, has this changed? Is the pain occurring earlier in your runs? Are you able to run anymore? You know, when you switch to biking, does it still bother you? Can you do the stairs to get into your house? These are the types of questions we ask. And we want to know, are you having daily pain? That's another important question that's really helpful to us in helping the patient make that decision. But I would say we typically reflect those questions back because it is the patient's decision. Sure. We manage the symptoms more so than the radiographic finding.
You wanted to add to that?
I think that's an important point, that there's never a time when you have to do a joint replacement, when a professional, a physician should tell you, we need to replace you have to have a joint replacement. It's always an elective surgery. The elective means that you have a choice. And how you make that decision is difficult. All those questions that you've heard are very, very appropriate. We are also at UMass Memorial one of the leaders in the field in helping patients with this by providing them tools. And we have a computerized patient questionnaire that's validated and been used by hundreds of thousands of patients that can grade the patient in terms of where they are versus age-matched controls, people their age who do not have arthritis, and they can look at the severity of their disability, the limitations of their function, as well as the severity of the pain. Because for each individual patient, they don't have a frame of reference, but by using these types of validated tools, which are now available online as well, we can help the patients understand where they fit in the spectrum of the disease process.
I'm going to have you show us another prop, this one of the hip, correct?
Correct.
So this is another joint that can exhibit itself in terms of pain and replacement with this condition?
So the two most common joint replacements performed in the United States today are the knee replacement, number one, and the hip replacement, number two. Together, there's roughly 1 million joint replacements done per year in the United States.
Wow.
You know, a very, very large problem. The hip replacement, arthritis is similar, that there is no cushion. The articular cartilage has worn away. The hip is a ball and socket joint, so it affects the articular cartilage on the ball as well as in the socket. So the joint replacement itself makes up a plastic sandwich, again, to replace the cartilage. Here, there's a metal shell which fits into the pelvis, into which a very high density, very tough polyethylene liner fits. And then there's a metal ball that replaces the femoral head, or the ball that's at the top of the femur, the thigh bone, which is attached by a stem that goes into the thigh bone. So the hip replacement looks like this, again, with a metal sandwich. And on the metal that goes into the bone, there is a roughened surface that has a sandpaper finish, and the surgeon will fit this very precisely into the bone so that it has intimate contact up against the bone inside the femoral canal, which is the middle of the bone, and bone will grow into this sandpaper finish. So the patient's own bone grows into this metal porous coated surface, and that provides long-term fixation of the metal to the bone.
Dr. DeMarco, I know this, not the hip, but looking at the various steps that go into the surgery and what needs to be done in joints, how did you prepare for this surgery?
Yeah, that's a very important aspect of the whole procedure, and it's one that we as rheumatologists discuss with our patients. For me, it was really a 6-month process because of coverage that I needed at work. But for many patients, it's getting in shape if they're not already in shape. One of the hardest things, losing weight. I wasn't really in that category, but it was arranging my kids' lives. You have to donate blood, or you have the choice of donating blood. So it's not something that you make a snap decision about. So it is quite a lengthy decision-making process.
You're a doctor in the UMass system, so you are up on the medical terms, the understanding of the field, but it sounds like it still was, taking the doctor's hat off, right. A very personal decision, and one that, can you imagine, for someone that doesn't understand this field, a difficult decision? Yeah,
I think it was really important for me to take the doctor hat off because everybody assumed that I knew, the whole process that was involved, and I actually didn't. So I did behave like a patient. I went to the class that's run by the physical therapist, which was excellent. It told you what to expect, right after the surgery, what kinds of assistive devices you would need at home, like a walker or things in the bathroom, and that was really helpful. I wouldn't have known that, and so now it's helpful for me to tell my patients about that. But
sure.
But I think it was important for me to remove the doctor hat.
Dr. Bema, how do you prepare just the average person out there who is getting ready for the surgery?
We talk about some of those things. First, we make sure they have an understanding of what the cause of the pain is. Like Dr. Upchurch mentioned in the previous segment, we make sure there are no other factors. Is there some other underlying process related to this? And then if this is osteoarthritis, how bad are your symptoms? We go through that whole conversation. And then are there any modifiable risk factors, weight being the most important one and the most obvious one? And then just strength and muscle tone
Okay.
Also involving the family members. For example, my mother's had both of her hips replaced, not at the same time. Typically, that's another question I get. Typically, joints are replaced one at a time. It's not one-stop shopping. Wouldn't that be nice and easy? But it's much harder to rehab, let me tell you.
Yeah.
So my mother had her hips replaced one at a time, and it involves the whole family. Do you have stairs in your home? Do you have family support? Just to get back to things in the bathroom, lest we joke about that, what Dr. DeMarco means is, for example, if you have a hip replacement, you can't have your knee higher than your hip to protect that surgery. So what you need to do is have a raised toilet seat. So that's the thing in the bathroom that you need, should anyone have call in with that question.
Good note, good note. What is the success rate? Again, these are elective surgeries, but very necessary. So what can people expect?
So these are the most successful operations we do in medicine today. They're relatively new. If you look at the history of medicine, hip replacements began in the mid-60s and became popularized in the mid-70s. Knee replacements began in the mid-70s and became popularized in the mid-80s. But they are among the most common operations done in the United States today because they are so successful in relieving the severe pain of arthritis and improving the patient's function. So that's why there's been an explosion in the growth of these operations. Virtually everyone knows someone in their community or in their family who's had one of these, and many people consider it one of the miracles of modern medicine.
How long does this last? Is it a one-time operation? Do people have to go back in?
So these are lasting longer as we improve the prostheses. And let me go back to the model. I'll use the hip as a model. There are a couple of things that are important to the longevity of how long the prosthesis or the replacement will last. The first is, how is the metal fixed to the bone? Early on in the history of hip replacements, we fixed the metal to the bone with a bone cement. And the bone cement was a grouting agent, an acrylic. It worked very well, but that acrylic eventually fractured and loosened. These newer prostheses, where the bone grows into the metal, are much more durable and much longer lasting than the bone cement. So a modern hip replacement consists of a bone ingrowth fixation rather than cement fixation, and these last greater than 20 years.
Wow.
Both on the ball side that goes into the femur, as well as the cup side. So the weak link is the plastic that's inside the acetabulum or the cup, and this plastic again has been improved over the last 10 years. It's been modified, and it is much more durable than the original plastics that were used in the 1970s. This, we believe, will last at least 20 years as well. Wow. But it's made so that if the plastic does wear and fracture or fray, it can be removed so that the metal can stay in place and a new plastic can be put back in.
Wow, much less invasive.
Much less invasive should a second surgery be necessary.
Okay.
And similarly for the knee, again, the plastic in between the two metal runners is the area that can wear after years and years of use, and it's made so that this plastic can be taken out and a new plastic can be put in without having to take out the metal cap on the femur or the metal tray on the tibia.
That must give you a sigh of relief.
It lasts a very long time.
Dr. Ayers, what about any risk of infection?
So infection is a risk anytime you have a surgical incision or even a cut. And with a joint replacement, the joint replacement is very susceptible to bacterial infection. So prevention is the key. We have learned that preparing the patient before surgery is critical. And that means changing those things which can be changed in preparation for surgery. So that means stopping smoking. That means losing weight. We use special soaps for 5 days before the operation. We use special antibiotic cream that eradicate bacteria in the nose. And we use special mouthwash with a swish and swallow technique to eliminate bacteria in the mouth. So we take this very seriously at UMass Memorial. And that's why we have such a low infection rate.
If someone gets one side done, will they most likely to have to get the other, whether it's knee or hip?
So it depends the reason why they developed the arthritis in the first place. If someone had an injury or a fracture that led to the arthritis, then it's not very likely they will need the other side done. If they have a inherited or familial form of arthritis or an inflammatory form of arthritis, then yes, statistically they likely will need the other side done at some point. But exactly when is very difficult to predict. It really depends on the degree of arthritis and the amount of pain and limitation in function they have from that joint.
Coming out of surgery, people just can't get right up and run or hop right back on that hip. So talk to me about the process that you work or the field works on getting people used to these replacements.
Absolutely. We know actually getting out of bed sooner decreases patients' trouble with breathing problems or heart problems. So we do try to get patients out of bed right away. But once we do that, they have to work within their restrictions. And it really depends on the type of surgery they have, what those restrictions are. I think Dr. Ayers can probably tell us more about that. But operating within those restrictions, having a raised toilet seat, which may start in the hospital room and then come home with you, and having some of those modifications to get up and around while staying within the restrictions, and then slowly strengthening the muscles and waiting for the incision to heal before we get into the more aggressive activities, which would be later as an outpatient.
If people are thinking about doing this, probably number one question coming to their mind, if I go through all this, when am I going to feel like myself again? Any indication of that?
That is somewhat variable. It depends to a great extent on how hard they work at their exercises. You heard the importance of exercise, and that's important after surgery as well as before surgery. But the range, the people who recover the quickest recover in about 3 weeks. Wow. The people who recover the slowest recover in about 3 months. The average person is in the middle, somewhere around 6 to 8 weeks.
I love Dr. DeMarco's quote that PT is your job, physical therapy is your job. And I think it's important to realize at the outset that if you're going to make this investment for the time for surgery, you really want to make that time for rehabilitation as well. And that'll affect how quickly you get back to doing what you're doing. And as we discussed in previous segments, it depends on what you were doing. You know, there's that old joke, doctor, can I play the violin? Well, did you play the violin before? So I think these are important things to consider. But we do see patients getting better and better the sooner we get them out of the bed, the sooner we get them exercising, and the more compliant they are with those exercises, not only while they're with the physical therapist, but when the physical therapist is not there to tell them what to do.
And Dr. DeMarco, I know you're a great example of someone that was active before and still very active after. So how was that process for you?
Yeah, so that was actually the thing I was the most worried about, is what was I going to do, you know, for exercise after the surgery, and really the physical therapy becomes your exercise. I remember asking Dr. Ayers, you know, how soon can I go back to work, and he said, PT is your job. And that's true. I mean, if you really want a good result, you can't just, and I tell patients this, you can't just show up at the physical therapist's office twice a week. I mean, I was doing the exercises 3 times a week, but on the other hand, you don't want to be up on the knee and have it swell, because then you can develop scar tissue. So it's important to have a balance of you know, the restrictions with appropriate exercise.
Okay.
And the other bad thing for me is that I was also a swimmer, and Dr. Ayers told me I had to stay out of the pool for 3 months because of concern of infection.
Okay.
So that was tough.
So Dr. DeMarco, you had said that one of your fears was what you were able to do afterwards. Do you have any limitations, or do you know of other patients that have any limitations after getting this replacement?
Yes, in general, you should not really be doing any high impact kind of activity. So running is out. I always get asked, well, can you run anymore? I say, well, I could run, but not if I want the joint to last. So high impact activities are out. I know some surgeons have different, you may want to comment on this, but have different philosophies about singles tennis, skiing. Those didn't apply to me. Luckily, I liked biking and swimming, so I'm still able to do those. Walking, hiking is fine. So it's really just the impact activities.
Okay. And from your point of view, anything that people should definitely stay away from after these surgeries?
People should stay away from running and jogging and high impact activities, because they load the joint and they put a lot of force and pressure on the attachment of the metal to the bone, and that can lead to loosening of the prosthesis. So they should avoid anything that really pounds on the joint.
How do you evaluate the patient's response to the surgery based on what they could do beforehand and what they can do afterhand?
So one of the ways we look at that is by using the same validated questionnaire that we use before the surgery that helps to guide the patient in their decision about whether it's the appropriate time to proceed with an operation, that shows how limited their function is and how much pain they have. We can use the same survey after surgery, and we can quantitate exactly how much their pain has improved and how much their function has improved. And we can compare them to patients who don't have arthritis. So we have used that in a grant application at UMass Memorial. We were awarded a AHRQ federally funded research grant where we are the center that is leading a joint replacement national registry in the United States, where we are collecting all of that data on 136 sites spread all across the country. So we have a wealth of data, a wealth of information, and we believe that this will ultimately help to determine best practice in the United States for those types of issues.
Do you have any closing thoughts, any closing remarks for someone that's watching this that may have a lot of questions about any type of replacement surgery?
I think that it's important for patients to understand that they need to explore all their options. You know, many patients become paralyzed by fear at the thought of an operation, and it's understandable that they have concerns, but they need to understand that there is help for them. And there was a time when patients were told, wait as long as possible, wait until you can't stand the pain any longer. And we now know that you can wait too long, that if you wait so long that you stop going to the store, that you stop going out with your friends, and if you stop driving the car, people are less likely to get back to these things after the surgery. And that's why things like the validated questionnaire that we use that shows where a patient is in their disease process in comparison to similar patients without arthritis is very, very helpful. So you can wait too long. You don't want to wait until you're so debilitated that your muscles are weaker, your range of motion is poor. You should seek medical advice, and you should look at all of your options. And with the advances in surgery, with the advances in anesthesia, we do not use general anesthesia any longer for these operations. And general anesthesia is when you have an endotracheal tube put down your throat and you have a ventilator that breathes for you. The modern way to do this is with nerve blocks and spinal anesthesia. So the patient is breathing on their own. They can be as awake and alert as they want to be or as sedate as they want to be. And after the surgery is over, these patients are out of bed the same day as their operation and beginning to walk and beginning to do their exercises right away.
Presented by UMass Memorial Health Care. I'm Colleen Bamford. Good night.